Yeah, thank you. First of all, I want to thank you, Dr. Machana and Dr. Stack. And actually, we have this molecular tumor board for 5 years, 6 years already. And without your support from clinical science and precision medicine, I don't think we can make it this far. All right, so Dr. Machana want me and Dr. Stack to present some case. Actually, this case we already been discussed in our previous molecular tumor, actually in the past 6 months. I pulled these two cases because I find they are all very good examples of comprehensive molecular profiling, okay, application in clinical practice, especially in patient care, right? So this is, I just want to highlight here some of the information from clinical history. This is a smoker, okay, I just want everybody remember that it's a lung cancer and a smoker. And so this is a pathology report. Actually, this case was not diagnosed at Ochsner, it's from outside. I just have the pathology report. I don't have the slide to review. I don't have the picture. But you notice this report it actually is a very typical pathology report. Okay, for currently the standard of diagnosis lung cancer is we want to preserve most of tissue for molecular testing. We don't want to waste tissue on immunostain or morphology because if we call this is a lung cancer, it's a non-small cell, and we only do maybe 1 or 2 immunostains to give a relatively confirmatory diagnosis, but we don't do a lot of things because after we make that diagnosis, the most important thing the oncologists want to see is the biomarker. It's not like what it is, right? So I highlight here this patient has the outside pathologist called poorly differentiated pulmonary adenocarcinoma, and immunostain show positive for TTF1. Supriya is in the audience, and she is much better than me in that case. So TTF1 for me, for most of the pathologists, is okay. This is a lung adenocarcinoma with rare exceptions, right? And also in the pathology report, the pathologist mentioned ALK, recommended ALK, EGFR, blah blah, molecular testing recommended. At Ochsner, we do reflex testing. We don't need a clinician to tell us what to order. So, and Dr. Stack ordered Tempus. This is a Tempus report. When you have a lung cancer patient and you have an NGS report, the first thing looking for EGFR, KRAS. So you want to see those names, gene names, then okay, I have a very good targeted treat, right? I really want to see that name. If you look at this report, we don't have that name. So what do we do then? All right, so all the NGS report gave you explanations like what is gene for, what is function, what is association with disease, is this target or not, blah, 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 a lot of information. But as trained as pathologists, we are very sensitive to pattern. Okay, the first thing as a pathologist we are looking for is a pattern. If you look at the highlighted gene names, and if you look at the VAF, the variant allele frequency, they're very close, right? So, and they're different from other genes. So to me, to my eyes, these genes are a group. They define a most important clone functionally. Okay, for these genes, the top one is TP53. This is universal for all cancers, right? It's a tumor suppressor gene. Okay, no problem, loss of function, right? The second one is the, I highlighted KEAP1, right? KEAP1 is a gene, the function is relatively complicated, like a cell defense to some environmental stress, oxidative stress. It's complicated, but you can think it's functionally like a tumor suppressor, okay? And then the next one I highlight here is SMARCA4. SMARCA4 is kind of getting more and more popular and well understood in the tumor genesis of a lot of different cancers, especially in the thoracic surgery or malignancies. We have disease like thoracic SMARCA4 deficient undifferentiated tumor, all right, something like that. So, but this case, we already defined this case as a non-small cell lung cancer. So, by definition, we are not thinking about those tumors. Okay, the first step of reviewing NGS, I always like to see if this NGS, this molecular profile fits our diagnosis or not. So to me, right now, okay, the rest of the page, you can see super long, this is all VUS, okay? And notice here, I highlight here, the tumor mutation burden is super high, It's almost close to 100%. So based on these informations, this one is we do the blood test along with tissue test, and the blood test pick up the TP53 and the KEAP1 mutation at the same time. So the blood test and the tissue test agree, and I have no problem with the test quality, and I have no problem with the diagnosis. And put all this information, addition to the morphological, phenotypic diagnosis of lung cancer, I would call this one as a non-small cell lung cancer with SMARCA4 deficiency, a mutation, and a very high tumor mutation burden. This is my interpretation of the disease. So I just want to explain to the group, SMARCA4 is a key component of SWI-SNF complex. This complex control or regulate the DNA packing and eventually the gene expression. So again, you can think about this as a tumor suppressor. Basically, we have 3 tumor suppressor loss of function or dysfunction in this tumor, right? That is overall pattern of this disease. What I mean, all right? When I read about SMARCA4 years before, and I come across this paper. Actually, I use this paper for this case. This paper is published by MSK group. They reviewed close to 5,000 lung cancer cases. Okay, and specifically, they want to understand what is the function and the relationship between SMARCA4 mutation and lung cancer. Right. So some of the highlights from here is, they classified the SMARCA4 mutation in 2 classes, class 1 and class 2. And the class 1 is a truncating mutation, fusions, and the homozygous deletion, which is ours, right? And the class 2 is more mildly like a missense mutation in the WOOS. And class 1 is strongly associated with phenotype, loss of protein expression, which is a phenotype. We didn't do that. We didn't do SMARCA4 immunotherapies. No, we don't have the chance to do that. And very interestingly, you can see most frequently co-occurring mutations are TP53 and KEAP1, which we have in our report, okay? And strongly associated with history of smoking. Basically, this paper describe, just tell us what our patient is. Perfect match. Some data here, you see the top line, the A panel. The top line is SMARCA4 mutated patient, and the second line, third line is more like. Yeah, here is a TP53 and a KEAP1, right? So that's the data. And also, we know class 1 SMARCA4 mutation associated with poor prognosis. This is very interesting. Summarize a lot of information. Panel A shows the SMARCA4 deficient patient. If we treat patient with immune checkmark inhibitor, immunotherapy, the overall survival is much better. Okay, and panel F is among those patients who received the immune checkmarker inhibitor treatment, the difference of prognosis between the wild type and the mutated patients disappeared. Okay, so that is very strong evidence of clinical treatment in treatment patient with immunotherapy. Okay, and more interestingly, if you look at panel B, the SMARCA4 deficient lung cancer has significantly higher tumor mutation burden. Okay, panel C, the SMARCA4 deficient lung cancer has very low or negative PD-L1 by immunostate, expression by immunostate. So if we put this together, imagine you have a lung cancer. You only use a small panel. You only do PD-L1 and a small panel target panel. You take this patient as, okay, I cannot treat patient with immunotherapy because PD-L1 expression is low, and then you don't have EGFR, you don't have KRAS, you don't have anything, right? Only if you do a comprehensive molecular profiling, you can find the pattern, you can find the treatment. All right, so to summarize this, only 8% of lung cancer, non-small cell, has a SMARCA4 alteration, all right? and is strongly associated with worse prognosis. And the paper recommended to treat patients with immune checkmark inhibitor.
So from that molecular tumor board, he told me that your patient has a very bad tumor, but we were able to do neoadjuvant therapy. We did 3 cycles of neoadjuvant therapy, including a checkpoint inhibitor. There was minimal response in the tumor and slight progression in lymph nodes. Poor prognosis was an understatement because actually but despite cardiac clearance, actually died on the table in the operating room, which I haven't had happen in a very long time. But it was very helpful tumor board anyway.
Okay. The second case, we can jump to the second case. The second case sent to me by a pediatric oncologist, Dr. Corey Falcon, and he is not here, but I just want, present some clinical information here. This is a 9-year-old female girl, and in 1921 has a liver transplant due to a diagnosis of calcifying nested stromal epithelial tumor. Somebody heard about this before? Actually, I only read this in textbook. I never see one before, but I will show you why. And 3 years after, surveillance scan show lung lesion. Okay, a biopsy proved this is a metastatic of calcifying nested stromal epithelial tumor. Right. So I have the slides. I can show you why we call this one. And here is the nested epithelial component. Here is the mesenchymal component. We don't know what this tumor is. We just use a descriptive name, calcified nested stromal epithelial tumor. Okay, that's what it is. And characteristically, by immunostains, you have strong beta-catenin expression and WT1 expression. This is Tempus NGS. Tempus NGS reported CTNB1, which is beta-catenin, and third promoter mutation. All right, tumor mutation burden is low. So when I get this case, I really have no idea what this disease is. So I want to learn more. Okay, so this is a very nice review paper. It's from a pathology group. So they reviewed this disease from the pathologist's perspective, right? So this is a very rare tumor, and only less than 50 cases reported in the past 20 years. Maybe right now it's a little bit more, but it's definitely less than 100, okay? So it's difficult to understand disease because in the early phase of the study, we gave the different name. If you review literature, you don't know what you're looking for because a different author gave a different name. Let's make this disease so difficult. And we don't understand the disease at all. We don't know if it's epithelial, it's a stromal, it's a mix, it's a mesenchymal. We don't know. Well, we just know something like the clinical behavior is not that bad. It's a primary tumor of liver. It's like young people, it's more male. All these are very descriptive, but again, remember this is rare tumor, only less than 50 or 100 cases being reported, right? So in this paper, they list 48 cases they can find in the literature, one by one. You can see from this summary, this is part of it. Most of the case, if you give, you can treat the patient with surgical resections or liver transplant. After that, the patient keep disease-free. However, in one case here, patient developed lung metastasis and passed away, died after the metastasis. So our patient come to us with a lung metastasis. Remember that already failed liver transplant treatment. So another paper after the first paper I found is they studied the mechanism of the disease, and they specifically said in their study group they only have 7 cases. They found 7 cases, and their finding is different. They said 5 of the 7 patients who has follow-up information develop lung metastasis, which make the disease more aggressive, right? And they specifically said CTNB1 and TERT mutation, promoter mutation, is strongly associated with this disease. CTNB1 is a Wnt beta-catenin pathway, right? So now we have a difficult situation. This is rare disease. We don't know how to treat it. So this is another example. If you have a difficult case, the diagnosis or clinical scenario is difficult, then the option of treatment sometimes is come from the molecular testing, right? You understand the biology, you try to, based on the biologic logic, to find a treatment. So this is a phase 1 and phase 2 clinical trial. Use a drug called CAGLA. Okay, this is you basically you can understand is targeted the Wnt beta-catenin pathway, right? Even though the patient group in this clinical trial is lymphoma and some sarcoma, but they find at least it's a safe drug and target Wnt beta-catenin pathway and has some clinical response. So after the tumor board, we contact the PI of this project, of the clinical trial from UAB, and we discuss the case. And since we already tried everything, all right, failed liver transplant, failed standard chemotherapy, and we get this girl compassionate use of CAGLA. Okay, so ever since then, 6 months, symptom-free, no significant side effect, and the disease is stable. Okay, it's not significantly improving, but at least stable. So the plan is to treat patient with this drug, see what's going on, since we don't have much better options. All right, so that's the 2 cases I have for today. Hopefully you can see the power of comprehensive molecular profiling in patient management, cancer patient management. Thank you.